So we're now going to go on to assessment and management of AKI, and then we'll finish off by looking at CKD. And as I said, there's a lot less to cover with CKD. So I think they may have an AKI. What do I need to assess? The first thing would be, well, not necessarily the first thing, but one of the things would be, what is their renal function and what is their potassium level? So you need to know, do they have high potassium? Because if they've got high potassium, they are at a very urgent risk of going into arrhythmias. And similarly, you need to know, is this actually a kidney injury in the first place? So that's one aspect. Another thing you need to know is what is their volume status, because this will affect how you manage them. So to know what their volume status is, you'll be looking at lots of different things. So one thing would be their fluid intake and their losses, which if they're already a patient in hospital, that's quite easy because they might say have a catheter, they might actually have a fluid chart, you might know what maintenance fluids they're on. So if say they're taking in lots of fluid, but not a lot of it is going back out, that's either suggesting they were very dehydrated in the first place, or they've got an obstruction and that fluid is just building up. You might look at things like their capillary refill, their heart rate, their blood pressure, particularly patients who've come in acutely unwell. Those are really important. Their JVP as well, because if someone's got fluid overload, that's going to increase their JVP. Going simple again, so moistness of their mucous membranes, their skin turgor, so those are things on your general exam. Changes in urination pattern and pulmonary crackles if you're thinking that they might have pulmonary edema. So that's all very important to think about. In terms of possible underlying causes, so these really relate back to lots of things we've said, so I won't go into tons of detail, but you want to know, have they recently been unwell? What are their current symptoms? Do they have a history of heart disease, liver disease? Have they had an AKI in the past? What medications are they on? And that's not just because the medication could cause the AKI, you want to know if it's safe to carry it on. So again, shamelessly stealing from PassNet, I should be on commission at this point. We want to know, do they need to stop any of their medications because they're dangerous when the patient is in AKI? So we did actually have a question about, or a point about lithium earlier on. So lithium is something that you may need to stop when someone's in AKI, because it might actually mean that they're more likely to get lithium toxicity, for example. And you want to know, for example, if they've had a fall, how long were they lying down? Because rhabdomyolysis can itself lead to kidney injury as well. Urine dipsticks, so you might do a urine dip. Well, you should do a urine dip. It's less relevant in older people because there's more, it's questionable how accurate it is. But in most people, doing a urine dip will give you some information that you can use. So you'll be looking for things like protein and blood in the urine. White cells could suggest infection, but if you are thinking infection, you want to be looking at the other symptoms as well, and you're more likely to do like a midstream culture. And be aware that if you're analysing from someone's catheter, then you're more likely to get false readings, and that's partly because you're more likely to pick up infection, and it's also because the trauma of the catheter itself might cause the appearance of some hematuria in the urine. And then also you want to be able to stage this AKI. So you want to know what their creatinine level is now, and you want to monitor it over time. So if someone's in hospital, you will be doing that relatively regularly just to be aware of what way they're heading. Because creatinine is not going to immediately change when someone's at AKI. You might also monitor their urine output. That's a really good idea if somebody is experiencing AKI or CKD. So if someone's got a catheter in, that's ideal, or if not, then they may need to actually do that in a more manual way. So those are the two quickest and easiest ways to measure their progress over time. How does nephrotic and nephritic syndromes fit into this? So this is just to touch on for anyone who does like using those terms. So it's more about the way things are presenting rather than being a cause or an etiology in themselves. So when we went through those conditions earlier, some of them we said, this presents like nephrotic, this presents like nephritic. And just to get your heads around that those are not etiologies in themselves, which some people might think that's really obvious, but for me, when I was first learning them, actually, I kind of need it spelled out to me that that's what that is. So we'll now talk about management, which overlaps with the emergency medicine block as well in 4th year. So it's good revision all round. So there are 3 key questions you want to ask of anyone who you think has got an AKI. The first one is, what's their volume status? Are they hypervolemic or hypovolemic? Then what's their pH and what's their potassium? So the first question there. So if they're hypervolemic, so if they've got pulmonary edema, you're thinking about giving them a loop diuretic. Now, you might say, well, is a diuretic not going to make their kidney injury worse? So you need to weigh this all up, and it's not a simple one-size-fits-all. You may also need to restrict their sodium levels. In contrast, if they're hypovolemic, you're going to need to carry out fluid resuscitation. Now, I've said such as using Hartmann's solution. Now, for anyone who's looked at what's in different fluids, what you'll realise is Hartmann's is very high in potassium. So don't just automatically give it. You need to be aware of what their full picture is. So signs that fluid resuscitation is likely to help would be things like if you lift up the patient's legs and their blood pressure goes up, that suggests that they need to be given fluids. Or equally, you can give a 15-minute fluid challenge, and if they react well to that, then that suggests you need to give them more fluids. If they have high potassium, do not give them Hartmann's, because you'll be doing all these things to lower their potassium, and then you look at the bag of fluid and you realise you're just giving them more potassium. So in that case, switching to like a 0.9% sodium chloride would be a good alternative. The next thing to think of is their pH. So a lot of the time, someone who's in acute kidney injury will have some degree of metabolic acidosis. So if it's severe, their pH is below 7.2, then NICE suggests that this is the point you would give them IV sodium bicarbonate. If they're not below that and they're a bit acidotic, you may be able to just supportive manage them until they're able to recover their own levels of acidity and alkaline in the blood, get them to a neutral pH. But if they are severely acidotic, you need to do something about that. Consider putting them in intensive care for closer observation. The sodium bicarb should only be used if venous bicarbonate is low as well. So you don't want to just give them more bicarbonate if they've already got a lot in their system and it's not helping. And you don't want them to have signs of volume overload either. So there's lots of considerations here. If you rapidly try and correct their acidity, you'll get a drop in their calcium level, and that can lead to all kinds of other problems. So if you've looked up what hypocalcemia can do, it's all the way from seizures to cardiac instability, and that's very bad as well. So this is why you might want to give it in an ICU setting, because you may need to be correcting their calcium, and if anything goes wrong, you need to be in a setting where you can deal with that. So I'm not going through how to look at blood gases, but looking at blood gases is really important in renal medicine because you need to know if they're in a metabolic acidosis. So this is where their pH is lower, their CO2 may be the same or it may actually be reduced. So if someone is breathing a lot to try and blow off their acidity, then they might have reduced CO2. And their bicarbonate will be reduced because they are using the bicarbonate to try and compensate for their acidosis. They've got a low bicarbonate level. So those are the key features of a metabolic acidosis. And that's something that I'd recommend you pretty much know off by heart because blood gases, again, very common exam question and very useful on the wards as well. So then one of my nerdy favourite topics is how do you manage someone who's got high potassium? It's very commonly asked when you're on the ward. So if it's something, if you're going onto the block and you want to sort of know how to impress, then knowing the ways that you manage hyperkalemia is a really good one. So the first thing is prevent further accumulation of potassium. So that's like stopping their bag of Hartmann's and switching to sodium chloride. You then need to stabilise the cardiac membrane. So something you want to do very quickly in someone with high potassium is to take an ECG because you need to see whether they're getting their tall-tented T waves and their features of hyperkalemia that could lead to them going into a deadly arrhythmia. So you can give IV calcium gluconate, which for a brief time stabilises the cardiac membrane. This does not solve the hyperkalemia, but this buys you time to solve the hyperkalemia. Then you can shift the potassium into the cells. Now again, you're buying time here. So you can give them an IV infusion of both insulin and glucose. And using the insulin helps you to shift potassium into the intracellular compartment while maintaining your blood glucose because you've given them glucose. So you wouldn't give insulin on its own because then you're just causing them to reduce their blood glucose rapidly, and then you've got another problem to deal with. So that's why they're given together. And also, interestingly, salbutamol promotes potassium moving into the cells. So all of these things, they take a little bit longer to start acting, but they also last a little bit longer. So you'd stabilise the cardiac membrane first, then you would do these different methods from shifting potassium into the cells, which again buys you more time, and then you can think about removing potassium. So if you're correcting their AKI, you might not have to actively remove that potassium. But in case you do, the things that you would use, you've got calcium resonium, which can be used to essentially take the potassium out of the GI tract. So that's what you would use in the more mild to moderate cases, if you're not able to just quickly resolve the kidney injury and it's all fine. But if the calcium resonium isn't working, and if you're at a point where you've tried everything else, you're going to need to go on to dialysis. Dialysis is your end line for if someone's got hyperkalemia you can't deal with in any other way. Dialysis is guaranteed to solve it. Important thing to bear in mind here, when I said about stabilising the cardiac membrane, if you're then going to spend over 30 to 60 minutes dealing with that patient, you may need to re-stabilise it again. So don't just assume because you've dealt with one stage here that you're not going to need to go back to it. But these are all the components of dealing with hyperkalemia that you should be aware of. And again, Geeky Medics has a really good summary of this. So for the last sort of 20 to 30 minutes, and I'm hoping to finish a bit before 8 o'clock, we're going to talk about chronic kidney disease. So most patients with AKI will recover with pretty much normal renal function, but there's a significant minority that have long-term reduced kidney function due to the AKI, and they go on to have CKD. So that's why I'm talking about CKD second. But there's also people who will develop CKD without the AKI, or some people with AKI develop CKD and then continue to deteriorate. So we want to know, what about these people who've got CKD on its own, or they're continuing to progress in CKD? Why is that? So first of all, we'll have a look at what CKD looks like. As I've said, it's gradual, often progressive, and it's encompassing all of the kidney functions. So whereas with AKI, we were thinking more about your electrolyte imbalances, your urea, your creatinine. With your CKD, because it's longer term, then you're going to get the influence of your reduced erythropoietin, your problems with processing vitamin D. You're getting those other functions coming in, and you can have a much more varied picture. So it'll be insidious over months. They might be fatigued, they might have reduced appetite, they might have nausea. Edema is quite common, so they can have quite pronounced edema by the time they're presenting. And then you will have the changes in their protein levels, in the blood, in the urine, in addition to that. And they may have to change their diet in order to compensate for these various factors. So it's very varied, which is why I'm not doing cases here. But what you'll want to recognise is that there are lots of things that play into CKD. So I'm not going to ask the next question, which why do they get each of these features, because we did cover it at the start. But the question I will ask is, in the UK, what do you think is the most common cause of chronic kidney disease? So if you could post in the chat, what do you think is the most common cause of CKD in the UK? So it could be something we've seen already, or it could be something different. Okay, so yeah, we've got a few people saying diabetes. We've got a couple of people saying hypertension. Good. So the two that you've mentioned there are the top two. Bryant suggested horseshoe kidney. So horseshoe kidneys, they do cause a type of CKD, and we'll come back to it, but it's not going to be one of the most common causes of CKD, but it's a really good point to mention. So we'll talk about classification, and then we'll go through actually the answers to that. So when we talk about CKD, stage 1 CKD is actually pretty common, because It's people who have normal kidney function but have some evidence of damage. So that could be that when you look on a scan, they've got a horseshoe kidney. So that's the example that Bryant was suggesting there. It could be that they've got random lab findings of hematuria, proteinuria, not just a one-off, it is consistent, but their kidney function itself is fine. Their GFR is still above 90. Or they've got some sort of evidence of kidney damage on a pathological diagnosis. So that's stage 1. Stage 2 onwards is when their GFR starts to drop. So their glomerular filtration rate is below 90. And you do need to know the different gaps between the stages, not least because you'll be asked it on a ward. So stage 2 is between 60 and 89, 3A is between 45 and 59, 3B is between 30 and 44, stage 4 is between 15 and 29, and stage 5 is below 15. So most people with CKD are in stage 1, but as people progress down the stages, they start to get more symptoms of having CKD. So what I've tried to show here is actually a horseshoe kidney. Now, what I've done, I've gone through a CT scan and I've taken screenshots of 2 different planes. So if we look at the right one first, you see that you've got 2 kidneys, quite easily visible. But as you progress through the planes of the CT, they sort of come together. And that really shows what the horseshoe kidney is, because it's where the kidneys are connected together like a horseshoe. So that person, their kidneys might function totally fine, but they've still got stage 1 CKD because they've got a radiographical abnormality. And then etiology. So this is the question that I asked. So diabetes is the most common cause of CKD in the UK, followed by hypertension. Everything else is in the less common category. So that includes things like polycystic kidney disease, obstructive causes, and anything that caused AKI and then went on to CKD would also come into the less common causes. So that's important to know in terms of etiology, that it's diabetes and high blood pressure. And that's why if you're in a GP setting, preventative medicine is so important. Regardless of how the CKD came about, there's then a cascade of events that occur in the kidneys. Now, if you're thinking about clinical exams, this is not likely to come up, but it's more for people who like to think about the patho to really help their understanding. So you get an increased pressure in your glomerulus with therefore getting hypertrophy of the glomerulus as the kidney is trying to adapt to the fact that they've got damage. Increased glomerular permeability to macromolecules. So because you've then started to get this hypertrophy, you've got almost spacing out, you're then getting more things passing through the glomerulus, you're then getting more toxicity to the mesangial matrix. So you end up with mesangial cell expansion, inflammation and scarring of the glomerulus. You are also getting more angiotensin II production. Now that's kind of almost like an inflammatory style of response, and you get renal scarring in the glomerulus. And all forms of CKD are associated with some form of tubulointerstitial disease. And that can be because you've got reduced blood flow. It can be because you've got inflammatory mediators, you've got lymphocytes. So there, as I said, it's a cascade of events that occur after some cause of renal injury. So that's quite general. And that's why I said with CKD, there's a lot less to explore, because if someone comes in with CKD, unless it's following an AKI, it's generally diabetes or hypertension, and then they've got all this intrarenal damage that's occurred because of a cascade following. So this is a nice little scan showing polycystic kidney disease. So that's one of the less common causes of CKD, but also one that is quite prevalent and is worth being aware of. So I've got another pot question here. So a 35-year-old man who has a history of high blood pressure and subarachnoid hemorrhage presents with recurrent UTIs and episodic hematuria. So if you've covered the block, you might know the answer. If not, feel free to hazard a guess. What is this a stereotypical history of? Okay, so we've got one answer of adult polycystic kidneys, and someone likes that as well. Does anyone disagree or have an alternate answer? Cool. Okay, so from the couple of likes there, I'm guessing most people are in agreement of adult polycystic kidneys, and you're absolutely right there. The hint was also the fact that I just showed a scan of polycystic kidneys. Probably should have put that afterwards. So thinking about management of CKD, stages 1 to 2 without uremia. First line is blood pressure control, essentially. So you've got your ACE inhibitors or your angiotensin receptor blockers if ACE inhibitors are not appropriate to the person. And you always add a statin because you want to lower their risk factors as much as possible. Second line would be your calcium channel blockers plus your statins. Now, as I understand it, the way that the blood pressure control guidance has changed is that anyone who's got CKD would now be on ACE inhibitors first. I don't know if anyone wants to confirm that in the chat because it is a bit confusing to understand. But broadly, this is what NICE guidance is saying, is that you start with your ACE inhibitors and then you go to your calcium channel blockers. Then second, when you've got stages 3 to 4 without uremia, it's as above, but you need to start giving them education on renal replacement therapy because unfortunately, by the time they've gotten to that point, it's more probable that they're going to need renal replacement therapy, which is when they're in stage 5 and or they've got high levels of urea in the blood. You're then thinking about renal replacement, which is either dialysis or kidney transplants. So I've given the answer away there. So renal transplant and the 2 forms of dialysis constitute renal replacement therapy. Does anyone know what the 2 types of dialysis are? If you do, then just post in the chat. So the 2 types of dialysis. Hemofiltration, good, and peritoneal, perfect. Yeah, so it's peritoneal dialysis and hemodialysis, perfect. So around 10% of those with CKD will go on to develop what is broadly considered renal failure. So stage 5 of CKD, which is your GFR below 15. Equally, we can consider it as people with uremia. So for those patients, the management options are either hemodialysis, peritoneal dialysis, or renal transplant. So for the last portion of this session, we're just going to briefly go through each of those. So the first thing I'd like to ask you, because this is something a lot of people probably know a bit about, what are some of the advantages and disadvantages of dialysis? So you can start with whatever you like, advantages, disadvantages. Could we just have some ideas posted in the chat? Time consuming, good, that's definitely a disadvantage. Expensive, yep. Particularly if people are thinking of, say, having home dialysis as well, that's also very expensive. Yeah, fatigue. Because people with CKD already have fatigue, but then also if you're thinking about they're going to need the EPO injections potentially if they're not having their kidneys replaced, and it's very time consuming as well. Yeah, Chloe said about holidays and traveling, like it is a big demand on life. But yeah, a positive is they don't need those lifelong immunosuppressants. Which, I mean, I suppose very topical. If you think coronavirus at the moment, people who are on immunosuppressants are having to shield for months, whereas people on hemodialysis, I actually don't know if they probably do fall into the category regardless, but immunosuppressants are something that do become a consideration, and it's a daily tablet people are needing to take. Only option, okay. Isn't there a limit to dialysis? I'm not sure what you mean by that. Would you be able to just expand in the chat what you mean by isn't there a limit? Just while that's being typed. Other things you might consider, so people on dialysis need to have quite strict control over things like diet, because you need to make sure that you've got the right components in the blood when you're filtering through. I heard of patients who have dialysis for many years and the veins are no longer usable. Okay, good, right, I see what you mean now. Yeah, so when people are having particularly like hemodialysis, they need to have an arteriovenous fistula put in, and after a while those sites may become unusable. They have to have other sites put in. So yeah, that's a really good consideration as well, and we will have a look at that. Okay. So you need to consider lots of things when you're deciding what a patient's going on to. And this is beyond just thinking about the fact of renal transplant, are kidneys available? There's also things to do with quality of life, which everyone was really good at touching upon there. And also, what does the patient prefer? Do they like the idea that when they go to sleep at night, they can have the peritoneal dialysis filtering through the night, or do they prefer hemodialysis, the idea that they just go, they have their treatment several times a week? So hemodialysis is the most common renal replacement therapy. It involves filtration through the machine in hospital. This is often around 3 times a week. It might be moved to more often. Some people are very lucky and can have it less, but they're often very time-consuming sessions, which people seem to be aware of. So 8 weeks before the treatment, the patient goes under surgery to have an AV fistula put in. I'll show you a picture of that in a moment. And that's what's used for the hemodialysis. Some patients can be trained to perform home hemodialysis, but that's still not particularly common. So this is what a fistula looks like. For anyone who might have missed the block due to things that are going on at the moment, I would suggest that at some point when you're back in clinical practice, try and find the time to see a fistula in real life. So what happens, if you look at the diagram, they're combining an artery and a vein together. And because arteries have higher pressure than veins, that then causes engorgement of the vein. So if you think someone who's having blood taken a lot, their veins become very bruised, not very usable. Whereas if someone's had a fistula made, it's a lot easier to put high volumes of blood in and out through that particular vein. So that's why you have the fistula made. This one's in the elbow, and the ones that I've seen have been in the wrist. Generally, it can be at a few different sites, and if one becomes unusable, you move around the body. As a med student, it's good to be aware of what a fistula is, because if you take blood from it, people are not going to be very happy. You'll get great blood flow, but potentially you could be damaging a site for someone's dialysis. When you put your fingers on them, it's almost like a buzzing sensation. It's really strange because you've got such a turbulent high blood flow going from the artery into the vein. So that's just a point of interest for anyone who hasn't seen one in real life yet. This is one of the risks. So this is something that I saw on Twitter, so I can't credit how reliable it is. So if someone got an injury to the AV fistula, there is a potential for very rapid blood loss because it's essentially damage to the artery vein connection. So that high pressure that goes to the artery is coming out of the fistula. So this is a patient who's evidently that's happened. And what they've done, they've put a bottle top on top of it. And it seems to have been effective at clotting the blood. Doesn't look particularly pleasant, but that's potentially saved their life. So that's just an interesting point about fistulas and highlights the fact that injury to a fistula can be life-threatening. Comparing that to peritoneal dialysis, so this is where the dialysis occurs through the abdominal cavity, so it's actually filtering through the peritoneum itself. So there's a permanent catheter that's put into the abdomen, and then whenever they're having this therapy, it's connected up to that catheter. So there's a high dextrose solution that draws waste products from the blood into the abdominal cavity, and then that's left for a while, which is known as dwell time, and it's drained back out of the abdomen. So you can either have the continuous ambulatory peritoneal dialysis, or you can have the automated one, which is overnight. And that's mainly patient preference, which one they would go for. And just to help you better visualize that, so you've got the catheter, which is going through the abdominal wall, got a solution bag, which filters it in, and then you've got a drainage bag that filters it out. So you've got the fill phase, where it fills into the person's abdomen, the dwell time when it stays there to help the filtering into that dextrose solution, and then the drainage time where it comes back out into a bag. So that's peritoneal dialysis. And then finally, you've got renal transplant. So in the UK, there's an average wait of 3 years. So it may not be an either or situation. It may be someone who's going to have a renal transplant, but they need to have dialysis in the meantime just to keep them alive in that interim. So the average wait is 3 years. It can be from a live or deceased donor. Hopefully you're all aware that there's been a change to organ donation where now it's an opt-out scheme, so hopefully that will increase the amount of kidneys available. The donor kidney is put into around the groin area. I'll show you a diagram in a moment. And the renal vessels are connected to the external iliac vessels. So you're essentially adding in a kidney to a new position. You don't remove the old kidneys, mainly because you don't need to. And what's the point in having a bigger surgery than you have to? Following transplantation, the patient does need to take immunosuppressants. Now, this was mentioned in the chat as a disadvantage, and that's to prevent rejection of the new kidney, because even the perfect match isn't the same as having your own kidneys. Donor kidneys don't last forever. So living donor ones do last longer, but after 15 years, that kidney is still going to fail and they will either need another transplant or to go on to dialysis. So again, people who've had kidney transplants often do find it a big release because you're not having to go to the hospital several times a week, but there is bearing in mind that they will eventually need a repeat treatment or to go on to dialysis anyway. So this is just a diagram to show you where that new kidney would be put in. So it's added in addition to the existing ones.